End of the Ashraf, please come here, occupy the seat on the dais. So, as you know, this course we have been doing not only in APAO for so many years, but also ASCRS, ESCRS, American Academy as well. I have to thank my guru Amar Agarwal for the wonderful innovations, what he have done. So, glued IOL. So, what we are going to do is, I am going to talk about after PCR what next, and Amar Agarwal will be talking about glued IOL. Sujata will be talking next on suture scleral fixation, and then followed by Amar Agarwal, and then Nivian, and then Dr. Ravi Shankar. So we're going to cover everything, and we'll have a good time for discussion so that you can clear all your doubts. So these are my financial interests. Early recognition combined with advanced instrumentation enable effective management of posterior capsule rupture. Anybody who has not had PCR at all in this audience? Anybody has not had PCR at all? So anticipate PCR and traumatic cataracts, post-vitrectomy, posterior polar cataracts, brown cataracts, pseudo-exfoliation. So a couple of years back, I was presenting in Amritsar when Sardarji put up his hand and said, I have not had PCR. Then we found he was an ENT surgeon, Amar, because he came that because his wife was an ophthalmologist. So only if you are an ENT surgeon, you will not have PCR. So options available is that IOL in the bag, IOL in the sulcus, ACIOL, iris claw, SFIOL, Yamane, so many other ways to skin the cat. Ashraf was talking about some IOL exchange and beautiful pupillary reconstruction as well. And then, of course, we're going to focus on this. See, if you understand this animation, okay, this animation is the most important thing. When you have PCR, okay, if you have coaxial irrigation aspiration, coaxial means the irrigation and aspiration are in the same port. That will enlarge the PCR, and the PC rent will become more and more vitreous will start coming into the anterior chamber. Vitreous is like a tsunami. So once you hydrate the vitreous, it will come up. But if you have bimanual means the irrigation is separated from the aspiration, the irrigation is separated from the cutter, okay, then you can tamponade the break and prevent the hydration of vitreous. Whatever vitreous is there in anterior chamber, you can connect it. You can see here, this is one of my phaco trainees, you can see the date also, 2007. This is what happens to everybody, okay. So when you have a PCR, you can see what's happening, okay. You become jittery. You may be operating on a VAP or a doctor or something, because only for VAPs the PCR will occur. So there's a problem. So what is important is, do not pull out of the eye. Do not pull out of the eye. That's very important. If you pull out of the eye, what will happen? The PCR will become more vitreous. Then immediately I went in and did a bimanual vitrectomy. Always remove the vitreous first and then remove the cortex and the epinucleus. What will happen to the nucleus which has gone behind? Depending on the karma we have done. If you have done good karma, pray to God, and then you have done good karma. See what the nucleus is coming. Beautifully it's coming. So it's coming up, and then you can see. Ideally, you have to do a past planar vitrectomy and go in. So I can see this is another one of the former union. At that time he was a union minister in 2003. See what's happening. These politicians commit a lot of sin and then they come to you, and you can see here what happens. When the PC tear occurs, it's because the post-occlusion surge. Okay, I don't lose my calm. I don't withdraw my phaco probe suddenly or abruptly. I inject viscoat. The viscoat is something which is probably the best product of Alcon. Alcon is not paying me a single paisa. I'm telling you, the viscoat will go and plug the PC tear. It will go and plug the PC tear, and then immediately you shift to the right side port and go for the bimanual. Go for the bimanual irrigation aspiration. Whenever you come out of the eye, inject viscoat. Okay, so the PC tear does not enlarge. So remove the vitreous. At that time, the tricot was not available with us. But nowadays, you should use tricot. I will show you this thing. This is a post-operative picture. Again, you can see here, this is a patient. This is a gynecologist who came from Kerala, the neighboring state. She wanted a toric lens. The lens started going inside. I did an anterior assisted levitation of the lens and then went ahead and put a lens in the sulcus. So you can see here I'm putting a lens in the sulcus fixation. You can see this is a hydro rupture. You can see what is happening. Can anybody tell me what is the mistake I'm doing? I'm doing a multi-quadrant hydro dissection. See what's happening. Top it opens up. Why it opens up? Because every time you do a hydro dissection, you have to decompress the nucleus into the bag. Otherwise, what will happen? The pressure will start building up in the posterior space between the nucleus and the posterior capsule, and it will open up. As soon as I put the phaco probe, what happened to the nucleus went inside, said tata bye bye. Okay, so you can see a posterior polar cataract. One of the ophthalmologists who came to me from Tamil Nadu in a place in Tamil Nadu, you can see I did a fairly okay rexus. Okay, about 5 millimeter rexus. Don't do a hydrodelineation. There are 3 conditions. Don't do hydrodissection. One is a posterior polar cataract, another is a traumatic cataract, another post vitrectomy. Nowadays we have patients who have multiple injections of Lucentis or Avastin into the eye. You can see what's happening now. So I am taking the epinucleus and I'm taking. So far so good. I was telling him everything going on well. See suddenly what's happening. This is the problem with the posterior polar cataract. It is not a PCR. It's a PC dehiscence. There is a congenital dehiscence. You can see the 2 pillars on the posterior capsule. Inject viscode, go bimanual, then immediately put tricot, dilute tricot 1:4. Even God cannot see vitreous without tricot in the anterior chamber. Please understand this. Put tricot. Don't put too much tricot. Don't put too less. A good amount of tricot, a fairly good amount, which will delineate the vitreous so that you can remove the vitreous, and always do bimanual vitrectomy. Don't use sponges, don't use devicus, don't pull the vitreous. You can go pars plana also, you can go limbal also, whatever you are using. And then go ahead and inject, you can see another patient with the posterior polar cataract, you can see PC. Sudden deepening of the anterior and posterior chamber, and immediately inject viscode. Don't pull out of the eye, inject viscode. Create right side port. Don't use the main port. Create right side port. Do an anterior vitrectomy. Put tricot. This keep it in your mind always. At that time when you become jittery, when your adrenaline is flowing, you will forget everything. Okay? And you can see here. So what is this thing? You put a sulcus, lens in the sulcus. Don't leave it in the sulcus. Okay? This is a haptic 3-piece lens in a posterior polar cataract. Obviously you can put a lens, can't put a lens in the back. If you leave it in the sulcus, what will happen is, it will decenter. You see, you can see here, this is called the optic capture. The haptic goes into the sulcus, the optic is captured into the capsular rhexis margin. Okay, this is called the locking of the lens. If you lock the lens will not move a micron. The lens will not decenter. Otherwise, you keep it in the sulcus, the problem is they can decenter, they can produce UGH syndrome. The end point of the locking is the ovalization of the anterior capsular rhexis margin. That is the capsular rhexis margin. You can see this lens will not move a micron. You can see the postoperative pictures as well. If the small PC tear, convert into a posterior capsular rhexis, because the posterior capsular rhexis is much more stronger. Then you can go ahead with this thing. You can see here this is a slightly bigger PC tear. I am not able to convert to the rhexis. I went ahead and put a lens. See what's happening now. So if you have a PC tear like this, it's extending to the equator, very difficult to do a posterior capsular rhexis. So immediately I put viscode, you can see how this thing is there. But once I put a single piece lens into the bag, see what's happening to that tear. Okay, I'm injecting viscode every time I come out of the eye. This is the thing you should cover. Every time you come out of the eye, whatever viscoelastic, if you don't have viscode, doesn't matter. You can put HPMC, whatever viscoelastic you have. See, don't allow the chamber to collapse. Very important. When you have PC tear. See what is happening now. Because I have not converted that into a posterior capsular rhexis, there is a single piece lens which is going into the bag. You see how the tear is enlarging. Fortunately for me, the lens is quite stable. I left it like that and prayed to God, and patient did very well. Okay, you can see a femto patient. This is just because you got femto everything, it doesn't mean you have the problem. This is something which I learned from my guru Amar here. You can see here what is happening. This is a thing. When you have a PC tear, what happens is the pupil becomes small. You do not know where your sulcus is. Then you put a lens in a small pupil. The lens will go, one haptic will go underneath the rhexis margin, and the other haptic will go in front of the rhexis margin. Okay, and then next day you find the lens on the macula. Okay, but I'm just telling you. So just put iris hooks. Take that extra time. Put iris hooks. Then see the sulcus properly. See the periphery properly before you put a lens. That's again very, very important for you. Take that extra time. If you are in, so always in a posterior polar cataract, if you have mature cataract, do not know, look at the fellow eye. The fellow eye has got an AC IOL or a glued IOL or an IOL in the sulcus. I always give a high index of suspicion for these patients that these patients have got a posterior polar cataract. This is a posterior polar cataract. You can see here what's happening. I'm doing a femto for this patient, and this is a young patient. Other eye I didn't see. one of my associates, they didn't even look at the other eye. Other eye had a lens in the sulcus, and I just like that, all mature cataracts I do. So you can see what's happening. As I'm removing the nucleus, there is a huge, it's not actually a PC rent, it's a PC dehiscence. It's like two pillars on the PC. You can see the PC does not join there. So inject visco and then come out of the eye, bimanual IA, then put a lens, 3-piece lens into the sulcus and then capture it. Again, you can see here. So management is traumatic, subluxated cataracts, all this. Because I'm running out of time now, anterior-assisted levitation, and put an ACIOL. Very rarely we do that also. The patient is got a very old patient, and this is a posterior levitation. Retroiris claw lens, I think Nivian is going to talk about it, that, and nucleus drop and other things, and scleral fixation lens. I'll go through it very fast because all these are being covered. The take-home message, PPP or preferred practice protocols in PCR. Small PCR convert into PCC. Do not pull out of the eye, inject viscoat. Use tricot preservative free, 1:4 dilution. Bimanual anterior vitrectomy, limbal or pars plana. Remove the vitreous first and then remove the cortex and the epinucleus. Appropriate IOL. You can leave them even aphakic if you are noticing them, and consider maybe a glued IOL or something like that, or IOL in the sulcus. After a couple of weeks, when the fibrosis of the capsule also occurs, you are in a better frame of mind to examine the patient on the slit lamp, and then always suture the wounds. Why suture the wounds? Because please understand, when there is a vitreous loss, the incidence of endophthalmitis goes up by about 5 times. So I don't want any micro leaks or anything. So ACIOL, retroiris, sutured, glued, all these are going to be covered in this course. I thought I'll just give a introduction for the whole thing. Sulcus IOL, Yamane technique, and thank you very much. And please make a note of this calendar, 37th APCRS meeting in August in Ahmedabad.